Today, we are going to talk about celiac disease. Why we have chosen celiac disease? As you all know, celiac disease is not a very uncommon disease in India, which has got myriad of presentations. And the interesting thing is, the patient with this disease can land up in any department. I will be mentioning that in my subsequent slides. The slides are not moving. What is celiac disease? This is called as celiac sprue, gluten sensitive enteropathy, or non-tropical sprue. These are the names which have been given to patients with celiac disease. This is a systemic disease with a permanent intolerance to gluten. It is a chronic disease. It is triggered by a gluten ingestion, which is a complex of water-insoluble wheat, rye, or barley products in genetically predisposed individuals, which has got autoimmune enteropathy associated with HLA-DQ2 or DQ8, predominantly involves small intestinal villus abnormality in the form of atrophy, causes malabsorption of multiple nutrients, leading to different manifestations. Interestingly, gluten-free diet causes resolution of symptoms. That means exclusion of some diet helps in resolution of symptoms. And interesting part is the relapse of symptoms are there with reintroduction of gluten. So a disease caused by a nutrient leading to malabsorption, resolution of symptoms by exclusion of a diet in gluten high diet, and the relapse of symptoms when we reintroduce the gluten. That is the features of celiac disease. Coming to how the disease was diagnosed in the past. The disease was diagnosed way back in 250 AD. Why do we need to know about the history? Because this is important to know, because what our precedents are, our seniors and our people in the past, how much hard work they have put to diagnose this peculiar disease. This was first diagnosed in 250 AD, where it was called as a problem of digestion with chronic perturbation of digestion and anadosis. That means absorption defect, which was called as celiac diathesis. In 1988, Samuel B. published first modern clinical detail of description of celiac disease and the role of diet in this particular disease. In 1908, Christian Hatter linked celiac disease to growth retardation, for which for a long time this celiac disease was known as G. Hatter disease. In 1940, the main work done was by a Dutch pediatrician, how he came to know about this particular disease. What happened during the World War, there was scarcity of bread, which was not available to the patients in the ward of diarrhea. And one of the mother of a patient addressed this issue, that the patients who were not getting food in the form of bread, they somehow improved in their diarrhea. And once the war was over, when the bread was reintroduced, they had symptoms. So this particular observation was picked up by a Dutch pediatrician, and he linked that this particular disease was linked to somehow grain consumption, and the next series came in this particular disease. In 54, histological abnormalities in celiac disease were diagnosed. Later on, serology came in the form of anti-TTG, and in 1972, a linkage to HLA was done in patients with celiac disease. In India, the first report came from India in 1965. There was a big gap after that. Isolated reports came. In 2006, the prevalence was studied in school children, and it was seen around 1 in 3,310. This was the prevalence. And in 2009, number of reports, they came in pediatric population, especially from North India. Most of the reports came from North India, as North is a wheat eating area, whereas later on, few reports came from South India also, although it is a predominantly rice eating areas. What is gluten? Basically, this is a protein derived from Gramineae or Triticale tribe. Wheat contains gluten, which is a combination of monomeric water-soluble gliadin and multimeric water-insoluble glutenin. In rye, the component is known as sicillin. In barley, this is known as hodin. All these contain prolamine from other grains, which also propagate inflammation. Oats, although phylogenetically they are more distant, but they share some of the similarities which can induce symptoms in some patients. So gluten is basically proline and glutamine rich proteins, which activates immune response in celiac disease, and the high proline content makes the gluten resistant to, basically the proline has a characteristic that makes it resistant to the brush border enzymes, that is peptidases. As this component is not metabolized by peptidases, so a lot of gluten that comes as a load to the small intestine, leading to the injury to the intestinal mucosa. I will be telling how the intestinal mucosa is damaged by presence of gluten. The slides are not moving. How common the celiac disease is? This is not so uncommon. The prevalence is around 1%. However, what we see in our population, most of the cases, they remain undiagnosed. In US, the prevalence is around 133. And this prevalence increases in first degree relatives. That is the patient who is the case of celiac disease. If we test their parents, child or siblings, this prevalence is very high, 1 in 22. In Europe, the prevalence is just as in worldwide. Finland, it's more, although this is not a predominantly wheat eating area, but high prevalence is reported. In North India, it is 1 in 96. And out of them, atypical variety is more common. Female to male ratio is 1.3 to 2.1. That is, it's more commonly diagnosed in males as compared to females. Prevalence all over world is there. You can see from Asia, Europe, North America, even South America. Almost all over the world, this is distributed. And the figure is around 1% all over world. How celiac disease is induced by presence of gluten? This is very important to understand. What happens, the gluten peptides, they reach the lamina propria of small intestine through the leaky gut. What happens, the mucosal tight junctions, they become leaky because of increased intestinal permeability. How this permeability increases? Either due to some drugs or some bacterial dysbiosis, which induces disassembly of enterocyte tight junctions. So the first step which happens in celiac disease is a loss of tightness of enterocyte tight junction. Then the gluten peptide, which enters inside the lamina propria of small intestine. This gets deaminated by TTG or tissue transglutaminase. Thereby, what happens? This gluten peptide is presented to antigen presenting cells. What are these antigen presenting cells? These are dendritic cells and macrophages, which exhibit in a genetically predisposed person as MHC class 2 antigens, that is HLA-DQ2 or DQ8. So a person who is genetically predisposed for celiac, they have their antigen presenting cells with these haplotypes of helper HLA-DQ2 and DQ8. When this gluten is attached to these antigen processing cells, this complex triggers the helper T1 and helper T2 immune response. Thereby, what happens? This leads to mucosal cytotoxicity, inflammation, and autoimmune extraintestinal phenomena. So all these leads to, this is the diagrammatic representation of what happens in the pathogenesis of celiac disease in each area. I will just explain it. You can see this is the dietary trigger, that is the gluten peptide. This enters, these are the enterocyte, that is, this is the lumen, and this is the lamina propria of small intestine. So this is the brush border. What happens? The dietary gluten comes here. Through this leaky tight junctions, it enters inside the lamina propria. This is deaminated, and this is presented to antigen processing cells, which already has HLA-DQ2 or DQ8. When this deaminated gluten attaches with this complex and this complex is formed, this complex stimulates CD4 cells, which leads to TH1 or TH2 response, basically helper T cell and helper T1 and T2 response is stimulated, which leads to formation of antibodies, as well as NK cells are stimulated. Through NK cell stimulation, the cytokines in the form of interferon or TNF alpha that comes, which leads to mucosal abnormality in the form of villus atrophy and mucosal villus atrophy and intraepithelial lymphocytosis that occurs. This in turn leads to collection of intraepithelial cells. Here interferon, interleukin 15 that acts. In other, B cell response is in the form of anti-gliadin and anti-tissue transglutaminase, which leads to autoimmunity, and thereby intestinal and extra-intestinal symptoms, they appear. These are the antibodies which we test in serum and which leads to serology, which helps in serological diagnosis of celiac disease. What are the clinical manifestations? As I have already mentioned, that patients with celiac disease can present in any department. The varied presentation is, one is a subclinical celiac disease in which celiac specific serology is present. Patients, when we do endoscopy and duodenal biopsy, they have gluten enteropathy, but they don't have symptoms. The second group is potential celiac disease, in which the celiac specific serology is there. When we do small intestinal histology, that is normal. These patients are known as potential celiac disease. They can develop celiac disease in future when they are exposed to different antigens or gluten in the future. Then comes the classical celiac disease, which is more common in children. They can come with diarrhea, abdominal pain, weight loss, nutritional deficiencies, Some of them, they can paradoxically come as chronic constipation also, abdominal distension, GERD, or obesity. So these are the varied presentation which can be seen in children specifically. They come with nutritional deficiency in the form of anemia. Iron deficiency anemia is a very common clinical presentation, or growth retardation. These are the common features which are seen in patients with celiac disease. Then coming to the non-classical symptoms, these are the symptoms which are more commonly seen in adult population. They can come with general symptoms in the form of anemia, fatigue, or abdominal bloating, or patients can land up in orthopedics department in the form of pathological fractures, osteopenia, or arthralgias. Patients come to gynae department with the symptoms of infertility, delayed puberty, or short stature. As far as liver is concerned, patients with celiac disease can have raised transaminases, they can have fatty liver, they can have autoimmune hepatitis, they present with primary biliary cirrhosis or cholangitis, or PSC or primary sclerosing cholangitis. So all these varied presentation can be there in patients with celiac disease. Patient can land up in dental department with tooth enamel defects, ENT department with recurrent F-third ulcers. These patients selectively, they have IgA deficiency, which is 10 to 20 times more common in patients with celiac disease. Associated celiac can be associated with number of genetic disorders also. Whenever patients with Down syndrome, they come with GI symptoms, we test them for celiac disease, Turner syndrome, or Williams syndrome. They have more association with celiac disease. Skin is a very common presentation in patients with celiac disease. Almost 90% of patients with celiac disease, more than 90% in fact, they develop dermatitis herpetiformis. In the opposite way, 20% of celiac disease, over a period of time, they develop dermatitis herpetiformis. How do we diagnose? We can diagnose this by skin biopsy, in which we see IgA deposits, which can be seen in dermis. This problem responds to gluten-free diet. How clinically these patients, they present with pruritic urticarial papules and vesicles on the skin of elbow, buttocks, and knees. So patients coming to skin department with skin problem, having underlying problem of celiac disease, which responds to gluten-free diet. So early diagnosis and treatment is very important in skin department also. Patients can land up in neurological department or neurology department with ataxia, which is known as gluten ataxia. This is basically autoimmune injury to the cerebellum. MRI shows atrophy of cerebellum in almost 60% of cases. The mean age is around 50 years. And the response to gluten-free diet, it may or may not respond. Second comes the gluten neuropathy. They can have sensitive neuropathy affecting hands or feet, and the age is around 5th decade. And the response to gluten-free diet can be there regardless of presence or absence of enteropathy in these patients. Interestingly, a syndrome has been described in which patients with celiac disease, they have ataxia and occipital calcification. So you can see the varied presentation with ataxia, neuropathy, and different presentation in neuro department. Then comes how and when we should recommend celiac disease screening in patients. What are the underlying diseases in which we should screen? One is the persistent unexplained pain abdomen, growth retardation, patients with fatigue, patients with unexpected weight loss, severe mouth ulcers, unexplained iron B12 or folate deficiency, patients with type 1 diabetes mellitus, autoimmune thyroiditis, IBS, and first degree relatives of celiac disease. Unexplained persistent raised transaminases are other areas in which we must get celiac serology done. Metabolic bone disorders, unexplained subfertility or recurrent abortions, unexplained neurological symptoms, Down syndrome and Turner syndrome. Look at the varied and various presentation to different departments and different specialties in which patient with celiac disease can land up. So the main diagnosis of celiac disease is, we have three main pillars. One is a serology, second is a duodenal histology, third is a genetic testing. Duodenal histology, we do upper GI endoscopy and we take duodenal biopsy. I will explain that. Coming first to the serological diagnosis. The main antibody which is important in patients with celiac disease is anti-TTG, that is anti-tissue transglutaminase IgA variety, and also serum IgA level. This can be done by ELISA and the quantification is also possible. This is a mistake in, this is basically ELISA. Why do we need anti-TTG, IgA and serum IgA level? Because when we screen these patients to TTG level, this is IgA variety. And if a patient is deficient in IgA, they have inherited IgA deficiency. In those cases, even the patient is celiac, but this response will not be same. So the combo of anti-TTG and serum IgE is the first test we do in patients with celiac disease, which has got sensitivity, very high sensitivity and specificity to more than 96 to 98%. Then comes the second important antibodies is anti-endomysial antibody, that is again IgA variety. This reacts to the same antigen of TTG, but the antigen is bound to tissues. This requires use of immunofluorescence in tissues from primates of esophagus and human umbilical cord. Although this is more expensive, technically more challenging, but and also operator dependent, and only qualitative assessment is possible. But the specificity of anti-endomysial is very, very high. So this is the most specific test which can be used for confirmation when TTG level is less than 2 times normal. In those cases, even if anti-endomysial is positive, then we can diagnose celiac disease. Then comes anti-TTG, IgG variety. Previously, we were doing IgA variety. Now, anti-TTG, IgG and anti-endomysial IgG. Both of them, IgG variant has got low sensitivity and specificity. So we don't order it. Many times we people they write only anti-TTG. So we must specify anti-TTG IgA and also anti-endomysial IgA, because IgG variant has got low sensitivity as well as specificity. Anti-glided antibody, although they were first to be diagnosed in diagnosis of celiac disease, they also have low sensitivity and low specificity. Recently, the work has been done on de-amidated glided peptide, or known as DGP IgG variety. This has got 88% sensitivity and almost 99% specificity. Especially, this is IgG variety. So people with IgA deficiency, they still be having this particular peptide which is positive. So we can diagnose celiac disease when patient is IgA deficient by use of this de-amidated glided peptide or DGP IgG. This is the algorithm which we use in patients with celiac disease for diagnosis. We do screening test in the form of anti-TTG IgA and total serum IgA level to take care of the patient is not IgA deficient. If that is found to be positive, we do confirm these patients with upper GI endoscopy and duodenal biopsies. If biopsy is consistent with celiac disease in the form of Marsh classification, which I will be explaining later on, that is, this is the confirmed celiac disease. If biopsy is not consistent, that means the biopsy is normal and we have only serology positive, these are the patients which are called as potential celiac disease. If anti-TTG is negative and total IgA, this is negative, the celiac disease is unlikely. But if we have strong clinical suspicion of this disease, then we get a HLA testing done. Then if HLA is positive, we do upper GI endoscopy and duodenal biopsy. If the biopsies are positive, then we say these are seronegative, basically seronegative celiac disease. And if HLA is also negative, then celiac disease can be excluded with almost 100% positive predictive. Negative, basically we can rule out celiac disease in that patient. We can have some false positive anti-TTG positivity in the patients with Giardia lamblia infection. Some of the patients with chronic liver disease can have this congestive heart failure. Patients with hypergammaglobulinemia and autoimmune diseases. So that's why we cannot diagnose celiac disease only on the basis of anti-TTG value, because false positive, although false positive may indicate potential celiac disease, but the sole diagnosis cannot be made by presence of only anti-TTG. We need other parameters in the form of either duodenal biopsy or this HLA testing before labeling it as a celiac disease. Falsely, patient may be celiac, but we may have negative TTG in the form of when a child is very young. In patients in less than 2 years, sometimes these antibodies are in low titers. Patient who has already been put on gluten-free diet, in those cases, the level of anti-TTG decreases in spite of being having celiac disease. Patients with selective IgA deficiency, because this is a IgA variant which what we are testing, if the person is already having IgA deficiency, so this response of anti-TTG will not be there. And patients with mild celiac enteropathy may not have this high level of anti-TTG. So we need other parameters to diagnose if we have strong clinical suspicion of celiac disease. Use of anti-DGP or deaminated gliadin peptide IgG variety. This is useful in patients in which small intestinal biopsy is consistent with celiac disease, but anti-TTG IgA is negative, or patients in which we have anti-gliadin antibody test positive, but who have IgA and TTG negative, or patients with severe IgA deficiency in patients. In those cases, this deamidated gliadin peptide IgG variety can be useful to diagnose celiac disease. What do we see in patients with endoscopy in patients with celiac disease? The endoscopic findings are very much sensitive. They are not so sensitive, but specificity is there to the tune of 99%. Patients can have mucosal atrophy, fissuring, and mosaic pattern, which can be seen in this diagram. But other features are also there: loss of duodenal folds, nodular mucosa, submucosal folds. But these are only the visual impressions. We must take biopsies to diagnose patients with celiac disease. At least we should take 6 duodenal biopsies. And as the disease is basically patchy to begin with, so multiple biopsies need to be taken. And 1 or 2 biopsies should be taken from the duodenal bulb. It has seen that it increases the yield in patients with celiac disease. And the biopsies should be taken with single piece at one time. This is very important. As a gastroenterologist, we must not use multi-bite forceps in which we can take 2 to 3 biopsies at one single shot, because the tangential biopsies by multi-bite may overestimate villus atrophy. And patient should be on gluten-containing diet. Why? Because if the person is already put on gluten-free diet, the histological changes may revert over a period of time, and we may not diagnose celiac disease if the patient is already on gluten-free diet in spite of taking duodenal biopsies. This is the histology or modified Marsh classification, which has been used, in which we see intraepithelial lymphocytosis. The level should be more than 25 cells per 100 enterocyte. The second is the crypt hyperplasia, which is seen in patients with celiac disease. Then comes the villus atrophy, and villus crypt ratio. In normal population, this is 3 to 5.1. When there is partial villus atrophy, then this ratio decreases. And when there is total villus atrophy, this ratio becomes almost 0. So the totally flat mucosa is seen in patients with celiac disease with florid manifestation. HLA-DQ2 and 8 typing, this is important in patients. This negative HLA-DQ2 or 8, this makes celiac disease highly unlikely. That is, the positive predictive value is almost 99%. Out of these HLA, DQ 2.5 has got more predisposition, and it must be distinguished from other HLAs in which there is low predisposition. This test should not be used routinely to diagnose celiac disease. Although this is not affected by dietary gluten, if the patient is on gluten-free diet, then other markers may become negative, but this test will remain positive. So whom to test? Patients already on gluten-free diet before testing, patients with MARSH 1 or 2 histology but negative serology to say that this person has celiac. Sibling of celiac disease for likelihood of disease. If they are positive for HLA, they are likely to have celiac disease in future. And in some patients with genetic and autoimmune diseases, in which we want to know the link between autoimmune diseases and celiac, in those cases, patients should get the HLA typing. Absence of HLA-DQ2 or 8 has a negative predictive value for virtually almost 100% cases. Usefulness is there in seronegative patients. Patients on gluten-free diet who are unable or unwilling to undergo a gluten challenge. Once a patient is already on gluten-free diet, and if you want to check for the serology or histology, generally we restart with gluten and then take the serology and biopsy. But some of the patients, they have increase in symptoms while taking gluten, who were already on gluten-free diet. They don't want to take this challenge. In those cases, HLA testing can be helpful. And patients who are refusing endoscopy, they can get HLA testing done. That comes the video capsule endoscopy, in which we pass a capsule. We give a capsule which has got an inbuilt camera made inside, and the capsule passes through the small intestine and take multiple photographs. We can check that just like Holter monitoring. That has got a sensitivity, very high sensitivity and specificity. Although the test is very costly, this is not used as an initial diagnostic test, except in patients with positive serology and who do not want to undergo endoscopy and biopsy. In those cases, this video capsule endoscopy can be done. The disadvantage of this is, although we can screen more areas by video capsule endoscopy, but we cannot take biopsy, because this is patient takes the capsule which comes out making a video of small intestine, and we cannot take biopsies. This is strongly recommended if a patient gets, say, complication in the form of, say, patient has got severe ulceration in the small intestine, multiple ulceration, or severe ulcerojejunitis. In those cases, by giving a capsule to the patient, which can take a photograph of entire small intestine, and we can know the extent of disease, or if any abnormal area is there, which can be seen by capsule endoscopy, where we can take biopsies. Extensive mucosal damage can be assessed by this capsule endoscopy, especially in type 2 refractory celiac disease. I will be explaining that in later. These are the radiological findings. We can get a barium done, we can get a CT done. We have typical findings of flocculation, reversal of fold, laminal flow, flocculation, dilution. And these findings, although they are not specific for celiac disease, but they depict malabsorption on barium. We can get some lymph nodes, we can get telescoping in intestine. We can have large volume in small intestine, large volume in colon. Basically, all these shows malabsorption. So all these findings, although they show malabsorption, they are not specific to celiac disease. They can be seen in disorders of malabsorption of small intestine of any etiology. So a triple combination of, we have seen that almost patients with genetic positive genetic test, that is HLA, positive anti-endomysial antibody, which is very specific, and more than 10 folds increased in anti-TTG. All these three combination can give almost 100% positive predictive value. So it can be used as a European guidelines. They have said that in patients, children with TTG more than 10 times of upper limit of normal, positive anti-endomysial antibody, we can make a diagnosis of celiac disease even without genetic testing and even without doing a duodenal biopsy. Some of the recent newer tests have come in patients with celiac disease. They are intestinal fatty acid binding protein, IFAP. This is a basically marker of enterocyte injury. This is seen in patients with celiac disease in higher level, which normalizes after gluten-free diet. This has got a role in protecting adherence to basically patient. If we want to see the assessment, if you want to assess the patient is adhering to gluten-free diet or not, in those cases, this value can be seen, or if person has accidentally ingested gluten, in those cases, we can do this level. Then comes the flow cytometry, which recognizes basically blood CD4 T cells, which binds to HLA DQ gluten tetramers. Thereby, this can differentiate patients with celiac disease from control, even on patients who are already on gluten-free diet. So flow cytometry has got its own value. F5, basically fatty acid binding protein, has got its own value. So these are the advanced tests which can be done in patients, although they are available only in selected centers. We may have in future these tests very commonly seen. Patients who have villus atrophy, although the most common cause is celiac disease, but we have number of causes of villus atrophy. They can be autoimmune enteropathy, combined variable immunodeficiency, patients with Crohn's disease, eosinophilic enteritis, different infections like in the form of giardia, Whipple's disease, tuberculosis, HIV enteropathy, tropical sprue, small intestinal bacterial overgrowth, different lymphoproliferative diseases, and a group of drugs which can cause this villus atrophy. So just by looking at villus atrophy, we cannot diagnose celiac disease. So that's why we need a combination of serology, histology, and if required, the HLA testing. What are the drugs which can cause enteropathy? These are the NSAIDs, which is very commonly used by the patients. Immunosuppressives in the form of azathioprine, mycophenolate, or methotrexate. ACE inhibitors, especially the olmesatran, has been linked to the villus atrophy in patients with duodenal biopsy or secondary to chronic diarrhea. We can differentiate celiac disease from non-celiac disease villus atrophy by doing basically the different population of cells which can be seen. If we have predominantly intraepithelial lymphocyte as CD8 cells, that shows this is celiac disease. And if this is a mixture of CD4 and CD8, that shows the cause of villus atrophy is non-celiac. I will skip this. A word about gluten disorders. Basically, gluten-related disorders can be in three forms. One is a IgE mediated, that is food allergies. Some patients, they say when we take roti, they get severe allergic reaction. This is IgE mediated food allergies. Then comes the celiac disease, in which wheat is taken, and that causes some immune injury leading to celiac disease, in which there is villous atrophy along with other extra-intestinal manifestation. A new term has come up as a non-celiac gluten sensitivity. What is that? That is non-allergic, non-immune mediated, in which we make a clinical diagnosis. How do we make? The patient says that they have symptoms correlation with gluten in injection. When we do celiac serology, that is negative. When we do duodenal biopsy, that is also negative. And these patients, when they are given free trial of 3 months trial of gluten-free diet, they respond. And when we reintroduce gluten, again the symptoms they come. So this is known as non-allergic, non-immune mediated, or that is known as non-celiac gluten sensitivity. This is a new term which has come up. Many patients, they come to us. Many patients, they come to us with these symptoms of malabsorption, or symptoms induced by malabsorption by ingestion of celiac gluten. So in those cases, patients can have basically non-celiac gluten sensitivity. How do we say when patient is already put on gluten? What is the treatment of gluten-free treatment of celiac disease? Basically, this is gluten-free diet, which is recommended to these patients. But some of the patients, they get refractory celiac. What is refractory celiac? That is a disease in which patient is already put on gluten-free diet, but they have persistent or recurrent symptoms. In those cases, what we do, we get a TTG concentration done. If concentration is positive, that means the patient is having some contamination of wheat in his diet, then patient is referred to dietitian. And if we do endoscopic biopsy, that also shows villous atrophy. Over a period of time, if patient continues to have pure gluten-free diet and still the villous atrophy persists, then we say this is a refractory celiac. If patient TTG concentration is negative, then that means the symptoms are not related to celiac disease. We must rule out other disorders like lactose intolerance, fructose intolerance, SIBO, this is basically mistaken, IBS, or pancreatic insufficiency. So other alternative diagnosis to celiac disease should be looked into. So non-responsive celiac disease, we have a very big 99 cases series from GB Pant Hospital, in which it was seen that the gluten contamination was the main factor which was responsible for non-responsive celiac disease. The second was the IBS, miscellaneous, or refractory celiac disease were only less than 10%. So the refractory celiac disease are of two types, type 1 and type 2, in which aberrant intraepithelial lymphocytes, if they are present, this is type 2. If there is no aberrant intraepithelial lymphocytes are there, that is known as refractory celiac disease type 1. How do we diagnose patients with refractory celiac disease? We review the diagnosis. We take a detailed clinical history for dietary review. We exclude other causes which can cause these symptoms. Then we test for aberrant T cell response. We exclude malignancy. This is the stepwise approach in patients with refractory celiac disease. The specific treatment for type 1 refractory celiac is steroid, azathioprine, or infliximab. So a word about refractory celiac disease type 1 is basically in which intraepithelial lymphocytes are predominantly normal. Their polyclonality of T cell receptors is there. They respond to steroid, budesonide or immunomodulator. Whereas type 2 is a basically aberrant T cell response is there. They lack surface CD8 and CD3 expression while expressing the intracytoplasmic CD3. So they are aggressive, leading to aggressive ulcerative jejunolitis. Lot of malabsorption are there. So type 2 variety, that means, is more severe, more related to enteropathy associated T cell lymphoma, and they do not respond to steroid. This is a very difficult condition to treat. When these patients they come, we may need immunomodulators. They have higher risk of lymphoma association. We have other drugs also. We can treat them with bone marrow transplant. And recently, newer drugs which are there is IL-15. The drugs which acts on IL-15 is a new promising therapeutic strategy which can be used in patients with celiac disease, refractory. What are the long-term complications of celiac disease? That is, long-term untreated patients with celiac disease, they have high risk of enterocyte associated T cell lymphoma. They can develop intestinal adenocarcinoma. These patients, they have higher mortality, especially when the disease occurs in younger age. This mortality is influenced by age at which diagnosis occurs, how severe the presentation is, how much the patient is adhering to gluten-free diet, and how much is the amount of gluten he is consuming. So these patients, they have almost 5-fold increased risk of dying from the infection or septicemia. So gluten-free diet improves most of the extraintestinal manifestation in celiac disease and celiac disease related complication, except for enamel defect, osteopenia and ataxia. Most of the extraintestinal features, they respond to gluten-free diet. What is gluten-free diet? When the diet contains less than 20 parts per million of gluten, that is almost 6 milligrams per day. Why I am telling this figure? Because patients with celiac disease, we tell them to keep a different containers for making food. Why? Because even the small 6 milligrams of gluten, which can be, if the same tawa or same chakla is used for making chapati for patients with the celiac disease, this much contamination can occur. So even the small amount of contamination by gluten can lead to non-response of gluten-free diet. Patients should be aware that there are certain gluten-containing other sources also. Patients, they say that we are keeping good diet which is free of gluten, but toothpaste, even the lipsticks, some of the capsule shells, they can have gluten in them. So that basically the tolerable amount of gluten is as low as 1/100th of a slice of a bread. So even the minimal amount of gluten can give rise to symptoms. What happens with gluten-free diet? The GI symptoms, they improve in 1 month. They disappear by 6 months of gluten-free diet. And the seronegativity, that becomes after 6 months. That means after 6 months of exactly responding to gluten-free diet, the patient can have betterment in symptoms also, as well as the serology also improves. The histology will remain positive. Even 70% of patients, they will have positive serology even after 1 year of gluten-free diet. And serology, basically patients who are on gluten-free diet, how do we monitor these patients? This is by doing anti-TTG IgA level, because quantification of this is possible. So we can say if the level decreases, that means the person is already adhering to gluten-free diet. Histology may take 2 to 5 years to normalize, even patient is already on gluten-free diet. So this is very important to tell the patient that gluten-free diet should be for lifelong. Although 20% of patients, once they achieve remission, if they restart, they can maintain their histological remission after gluten reintroduction. But when we do biopsies and when we do serology in these cases, intraepithelial lymphocytes and the positive serology can remain positive, and these patients are at increased risk of extraintestinal manifestation and later relapse. So gluten-free diet for lifelong is the treatment for patients with celiac disease. We have some of the alternative therapies which are under experimental trials. These are either we can modify the wheat grains. These are known as genetically modified, less immunogenic wheat grains can be developed. We are developing it, but we don't have that in market. Propyl endopeptidases. These are the enzymes which can degrade gluten so that becomes less harmful. Non-absorbable polymers, which has got high affinity for gliadin. So the gliadin attaches to these non-absorbable polymers, and that does not enter the lamina propria of small intestine. So less injury is there. That is also under development. We are in the phase of developing drugs that can act on small intestinal permeability and gluten deamination step. We have HLA, we are in the process of developing HLA inhibitors as a gene therapy, and some of the drugs are being developed, but all these are still experimental. So till the time these things are not there, we need to put the patients on gluten-free diet. So how do we monitor patients on gluten-free diet? Patients should be monitored at 6 months and then every yearly for gluten-free adherence. Symptoms, serology, micronutrient deficiencies, and associated conditions. They should test TTG, IgA, counts, serum iron, folic acid, B12, calcium, thyroid, vitamin D. All these parameters, they must improve if the patient is maintaining gluten-free diet. We can get a follow-up endoscopy if the patient is not responding or having persistent of symptoms despite gluten-free diet. Bone densitometry should be assessed in patient every 1 or 2 yearly. Vaccination against pneumococcal, H influenza or meningococcus is recommended because I have already told patients with celiac disease, they are at high risk for septicemia and some of these infections. So as preventive measures, they should be vaccinated for pneumococci, H influenza and meningococcal. So thank you.